Hello and welcome back to MedSynapse podcast, where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host, Dr. Smarika Bhatt, and today we are diving into essential and often misunderstood topic, the hidden danger of misdiagnosing fever and febrile illnesses. To talk upon this topic, we have Dr. Modi with us, who has impressive career span over 18 years, during which he has worn many hats from being medical director and co-founder of Kelvia Hospital to leading diabetic center. He has earned prestigious titles like the Fellow of American College of Physicians and Indian Society of Hypertension FISH. It's clear that his dedication to advancing healthcare and education is unparalleled. Let's start with the first question. What is the role of pyrogens in the development of fever and how do they affect the hypothalamic set points?
I think that's a wonderful question because it explains a lot of processes that happens in the body. Now, before we jump to that, let's understand how those things work in a normal body when there is no fever. So basically what happens is, let's give the example of probably an oven or a refrigerator to understand this. So there is a sensor in the refrigerator or oven which senses the temperature. And then there are processes in the oven and the refrigerator which change the way the appliance would behave to get the temperature to a desired level that you set as a user, right? So what happens is the sensor tells the oven that you need to elevate the temperature to 100 degrees Fahrenheit, or the refrigerator has to be told to get the temperature down to probably 4 degrees or 6 degrees of Fahrenheit, correct? So the processes start working. So basically there are two processes. There is a heat generation process and there is a heat dissipation or heat loss process. So those processes have to work in sync to achieve a particular temperature. Now let's come to the body. Now let's assume there is a thermogenic set point in the body, which we know is the normal temperature is around 37 degrees. So there are certain nuclei in the hypothalamus which sense the temperature. Now what temperature do they sense? There are two temperatures that you have in your body. One is the core temperature and one is the peripheral temperature. When we're talking of fever and we're talking of signs, we're talking of core temperature. We're not interested in the peripheral temperature because that can get changed and influenced by many other extraneous factors, which I won't go right now for the scope of this question. But the core temperature is primarily regulated by multiple factors, like you end up losing stools and urine, which also release a lot of heat from the body. But the primary processes by which you lose heat is through sweating. So when you sweat, there is a lot of evaporation of water from the body. Now, what happens is, I'll give you the example of water bodies like a lake or a sea. There is a huge surface area when water evaporates, and the specific heat of water is pretty high. So you end up losing a lot of heat when water evaporates. So it takes a long time. That is what the specific heat is. So you see, at the end of the day, the temperature in the people who are staying around a sea or a lake, that area becomes very cool in spite of being in the summer season, because a lot of water is evaporated throughout the day over a period of time, and that brings a lot of cooling effect to the air around. This is what happens more in the evening time, not in the night. It should actually happen in the day to relieve the summer. It takes time because of the specific heat. So from late afternoon to evening, you start feeling the cooling effect in these areas around the sea and the river. So similarly in the body, there is a huge surface area. We have a huge surface area for body, and you end up losing a lot of water through your perspiration. That keeps your temperature down. Another agency through which you lose water is by breathing. So when you hyperventilate and you breathe hard, you end up losing a lot of heat through your air that you breathe out. So these are the processes by which you lose or dissipate heat. Now, when you constrict your muscles a lot, when you exercise or when you're having rigors or when you're trembling and all, contract your muscles multiple times, a huge amount of energy is generated when your skeletal muscles contract. So that's another source of heat generation. And of course, this is something which the body needs to preserve. So when you come into the hypothalamus, when it elevates its set point to a point where fever has to be generated, like your temperature has to go up to 39 of such kind of temperatures in fever, then what happens is your body ends up producing a lot of heat. So you see these people have a lot of rigors and trembling, and they ask for blankets and bed sheets in spite of being in a summer season, because they have to preserve heat. And there is vasoconstriction around the sweat gland so that you don't end up losing a lot of water through sweating. And though these people hyperventilate because of fever, but the processes in the breathing is also taken care of so that you don't end up losing a lot of heat. So the whole process is working in tandem with each other, and it is the hypothalamus which decides how much heat should be generated and how much heat should be lost, so that you can achieve a set point, which is fever, and that can elevate your temperature.
Thank you so much, Dr. Alok, for shedding light on hypothalamic set points. I'm sure our audience will truly enjoy the answer. Let's move on to the next question. How can one systematically differentiate between infectious and non-infectious cause of fever?
So basically, there are certain very critical signs and symptoms which can help you in differentiating it. Let's understand what are infectious and non-infectious causes. Infectious causes are broadly classified as bacterial infections, fungal infections, viral infections, and other agents like parasitic agents. And non-infectious causes are also huge. You can have autoimmune disorders. You can have rheumatoid arthritis, rheumatic fever. You could have malignancies and cancers. You could also have fever because of drugs. So drug fevers are also well known to cause elevation of temperature. And there are many other non-infectious causes which can go on and on. But let's talk about how to differentiate between the infectious and non-infectious. There are various ways of finding out. You can do a good history taking, you can do an examination, and then obviously you rely on investigations in imaging modalities and non-imaging hematological and biochemical investigations to make your diagnosis. But what I would like to emphasize here is we see a lot of young early career physicians today jumping straight away to investigations and trying to determine the cause of fever through investigations, which is not the scientific and a proper approved method of doing it. Very few people realize that very basic investigations, like a simple CBC, complete blood count, urine and stool, give you a lot of information. They are cheap, but they're not given much value. And beyond that, something which I give more importance, which we were taught at medical school, is a good history taking. A good history taking and a proper detailed examination can give you a lot of clues about the causes of infectious versus non-infectious fever. I'll supplement with this down as I'm talking with examples. It's a huge topic. The answer can go on for hours. It's basically a classroom training over 3 to 4 hours. I'll try to shorten my answer. So, if a good history can tell you the duration, we used to have ODP, origin, duration, and progress of a symptom. So, let's say somebody is having cough for more than 3 months or 4 months. So, naturally, it's unlikely that you would have COVID or an acute flu or something, right? He would not have an acute viral infection. He would probably be having a chronic infection of respiratory disorder, something like tuberculosis or maybe even malignancy or something like that. Somebody comes with high grade fever with chills and a very rapid cough and a very rapid deterioration of his breathlessness. Breathing problem, gets very breathless very fast. You can start thinking of a community acquired pneumonia, a bacterial infection as a cause. Obviously, even COVID and swine flu can result in such situation, but they are viral. So you can differentiate between the acuteness and the chronicity of the illness, not only on the cough, but in other systems also, like in CNS disorders, like in GI disorders. You can have loose motions coming in very rapidly, very fast because of cholera or rotavirus viral infections, or you could have a slow, painful, but not very high frequency loose motions, but a painful and a little amount of hematochezia or blood in the stool, like amoebiasis and giardiasis can cause. Or you could have an asymptomatic person, absolutely asymptomatic, no symptom, little weakness, could be attributed to cancers of various kinds, could be attributed to diabetes, could be attributed to inflammatory bowel diseases, can also present like that. So a good history, I'm not going into the details now. A good history gives you a lot of clues. A good history of a sexual history of a person not answering his sexual history because of embarrassment and moralities could come out with it after you give a good empathetic approach and you're nice to your patient, but you probe persistently, you can find out multiple histories of exposure telling you that this person could be HIV positive or having a sexually transmitted disease. And then you can have histories which can tell you that it is non-infectious, in the sense that there is low grade fever, but there is absolutely no other symptom but just joint pain. And then there is a characteristic examination finding which you see in rheumatoid arthritis of the symmetrical kind of a behavioral pattern, which can tell you that this joint involvement is because of a non-infectious cause like rheumatoid arthritis. You could also have somebody not able to do certain things regarding his back, and his back pain is chronic and persistent for a very, very long time, and diagnosis has not been made significantly on multiple examination findings, and examination findings may not be much except for restriction of movement. And the real diagnosis comes when you do an investigation modality like HLA-B27 and certain kind of radiologic findings which you see on an X-ray, which tells you that this person could be suffering from ankylosing spondylitis. So sudden drop of eyelids, intermittently losing control on eyelid could be an early sign of myasthenia gravis, which is a non-infectious cause. So, moral of the story is a good detailed history examination, prodding into the ODP of a history, examining the patient looking for anemia, clubbing, icterus in jaundice. So you can have a clubbing suggestive of primary biliary cirrhosis, a bronchiectasis person in a lung. You could have other kind of cancers. You could have hepatocellular carcinomas causing clubbing. You can have congenital heart diseases causing clubbing. So there are so many differential diagnoses which open up. Now, congenital heart diseases coming with a little infection with infective endocarditis can give you fever as an infectious cause, and a cause of clubbing could be because of infective endocarditis, because of congenital heart diseases. So, a detailed history, a proper systemic examination, and then looking for a local examination of the classic symptoms of inflammation like rubor, duber. Duber means there is swelling of the lesion, there is redness or inflammation around the lesion, and there is pain in the lesion, there are symptoms in the lesion which tell you that there could be a hidden abscess or there could be a hidden carbuncle or something under the skin. Sometimes when we are taking rounds, we find that the person is on IV fluids for a long time, and the port where the IV is inserted gets inflamed, causing thrombophlebitis. And though the patient is doing well and getting well treated, the thrombophlebitis can cause fever. A detailed history sometimes can even tell you that the person is on drugs. A lot of people take OTC, over the counter drugs today, for various ailments, and they end up taking a lot of antibiotics that we see today, especially after the COVID era. I've seen a lot of patients taking antibiotics for cough indiscriminately, which is not ethically right, but that's another topic for another discussion. But that can also cause fever. So, probing into the history for fever, realizing that the patient is taking certain antibiotics, which can cause loose motion like pseudomembranous colitis, or a drug fever itself can be responsible for this. People with malarias and dengues who have been especially P. vivax malaria, sometimes they have been put on a preventive medicine like quinine and all. They have G6PD deficiency. They suddenly develop massive hemolysis and fever. And these are the people who are developing drug fever. That's not because of an infectious cause, but it has happened after a vivax malaria infection. So you start suspecting whether there's a relapse of fever or he's got dengue because he stays in a mosquito infested area. So a detailed history and examination can guide you. And then obviously you have investigations. I won't go into that, but certain investigation which I want to emphasize is a basic CBC, complete white count. Gives you a lot of information. So if there's a neutrophilic shift, toxic granules in the peripheral sphere of WBC, if there's a high WBC count, sometimes you get WBC counts to the range of 20,000 to 30,000, which is what we call as a leukemite reaction, which is not blood cancer, it's not leukemia. It tells you that there is a very massive bacterial infection. Sometimes you get atypical features like you can have a urine culture which is negative, but he has multiple infections of urinary tract, and you realize that this is a sterile pyuria, and you come to the diagnosis of tuberculosis of the genitourinary tract where the cultures are negative. So you can have fungal infections which be negative, and then you have to ask for a fungal culture. So a simple ESR, a simple C-reactive protein, can give you a lot of information about an underlying inflammatory process and an infective process. A simple urine examination and a stool examination should not be undermined, because pus cells in the stool and the urine and worms in the stool, or giardiasis or amoebiasis in the stool, can give you a lot of clues. Occult blood which is 3 plus and 4 plus persistently with absolute no symptoms and no signs and no finding can lead you to adenocarcinoma of the colon, and we pick up many patients like that. I had a patient who had intermittent, very mild loose motions occurring once or twice in a month and going on for 9 months, irrespective of what he was eating, and he stopped eating and he didn't understand what was happening, and the sonography was normal. And occult blood was always 4 plus, which was asked sometimes intermittently from various stool tests, but the previous clinicians did not give much importance to that. Finally, a colonoscopy and a CT of the abdomen revealed adenocarcinoma, which sonography had not picked up because it was in the initial stages. So, moral of the story is sonographies anyway don't pick up much lesions of the soft tissues like colon and all. So, moral of the story is every investigation should be explored in a proper manner. History and examination should be given their due credence, and basic blood and basic urine and stool examination should be given basic respect. A chest X-ray is of paramount importance. A chest X-ray can give you a lot of clues about various kinds of infections. It can tell you about osteomyelitis in the ribs. It can tell you about simple pneumonias. It can tell you abscesses. It can tell you past history of tuberculosis. It can tell you about certain metastatic lymphadenopathies. Nowadays, with artificial intelligence included, it can even pick up a pre-diabetic because of metastatic fat. So there are so many informations that you can pick up a subpleural abscess. You can pick up hernias which are getting infected from the migrating through the diaphragm. So the list is on and on. But the moral of the story is what you need to do is take a good history, take a good examination, go through all the investigations, join them like a story, and make them work out the pathophysiology of that patient, because each patient of each illness, like each malaria is different from another malaria, each dengue is different from another dengue, each rheumatoid arthritis is different from another rheumatoid arthritis. So all these stories have to be made into a good pathophysiology scenario, logically making sense, and then you can come to a very good conclusion and differential diagnosis by which you can come to a proper diagnosis and treat the patient. I hope I answered that question. It's a long question with a lot of ramifications and detailed answering. I just give a general principle. The essence of it is a good history, good examination, and interpreting your investigations in a proper perspective. And remembering that we are not here to treat the paper report of investigation, but we are here to treat the patient. So, correlating investigations with clinical symptomatology and sinology is very important. That is a scientific method and evidence-based method to practice medicine and come to a conclusion that so is the differential diagnosis and so will be the cause of the fever.
Thank you so much, Dr. Modi, for addressing the points. It was truly important for our audience to understand. Let's move on to the next question. What essential aspect of a patient history can help identify the cause of febrile illness?
Okay, so this is a very important part that you have asked, a very relevant question. What essential aspects of a patient's history can help identify the cause of a febrile illness? I think I've covered it already in the previous two answers, but I'll go into details now. So basically, what we have been taught in our undergraduate or medical school days holds true till today, that a detailed history makes a lot of difference in understanding the diagnosis of a patient. So getting different kinds of history, personal history, sexual history, occupational history, taking drugs. Today, we ask a lot of patients, what kind of drugs have you taken? And past medical history, whether he's been admitted in a hospital, whether he has allergies to certain medicines, whether any surgeries have been done, whether any blood transfusions have been given. Those kind of history collection is important. At the same time, an ODP is very important. Origin, duration, and progress. Take any symptom, whatever. List all those symptoms as 1, 2, 3, 4, 5, 6, 7, 8, or whatever he has, and take the origin, duration, and progress of each symptom. That gives you a detailed analysis. Remember, history will give you the temporal profile of a patient. It will tell you since when the person is having this symptom, how long it has happened, whether the symptom has increased or decreased, whether the symptom is influenced by other symptoms or not, whether there has been an intervention by a medical practitioner with certain drugs or surgery or not. And those things, when you piece them together, by the time you come to examination after taking history, give you a lot of answers as to the cause of fever. So suppose you're having cough, okay, and this cough is a dry cough, and it comes after eating a lot of food. It sometimes doesn't tell you that there is a respiratory illness. You might feel its cough is because of probably a pulmonary or a pleural cause, but actually this cough is only because of GRD. Many GRDs get missed like that. I'm giving you some atypical examples to make you understand how history becomes important, because the normal history taking I've already covered previously. So GRDs can present with cough. So gastroesophageal reflux disease or GRD may not present with acidity and burns, but it can present with a cough which doesn't get treated with cough syrups, which doesn't get treated with antibiotics. That's one clue to be kept in mind. Angina, which is something which is a different kind of an angina, right? So you don't get necessarily chest pain. You might get vomiting and nausea in an inferior wall lesion. These are called as anginal equivalents. And many times we miss a cardiac issue because we feel that this is a nausea and a vomiting. So it is a GI issue. And people go to a gastroenterologist and even have got their scopies done, whereas the problem is actually lying with the heart and not with the GI tract. Similarly, a chest pain can go as a dental pain. So, any pain which is considered to be a pain between the teeth and the umbilicus should be considered a chest pain of a cardiac etiology unless ruled otherwise. That's important because a cardiac pain could be life-threatening, whereas a dental pain is not life-threatening. So, people have gone to a dentist to get their teeth examined when they have thought that it is a dental etiology, but that pain is actually an anginal equivalent. It was pointing towards the pain of the heart and not to the teeth. So a detailed history taking and encompassing it with other signs. So suppose you're having a pain in the jaw area, right? It's not in the cardiac area, but you get breathless when you have a pain in the jaw, and there is a lot of sweating or diaphoresis. It definitely points you towards a cardiac issue. For example, if you have a lot of pain which comes after eating food, or it comes when you're walking after eating food, or only when you're walking, These are inguinal pains because there is compromised coronary supply. So because of an underlying plaque, so you're getting an inguinal pain. But if this pain does not relent down after taking rest and it continues to increase and the pain is so severe that you have to turn in bed with a lot of sweating, then this is generally suggestive of a myocardial infarction and not an angina. So there are different, I mean, of course, there are people who do not have any chest pain. They continue working very normally and nicely in spite of having a myocardial infarction running. And these are very typically seen in diabetics. A lot of diabetics have got silent MI or a silent ischemia because of autonomic dysfunction of the cardiac nerves. So this is another important history to be taken in mind, that an asymptomatic person with decreased work output or a decrease or a lot of sweating but no chest pain could be running a acute myocardial infarction, which needs to be attended to with a lot of emergency. And the golden 90-minute rule applies here also. There should be a very quick intervention by a medical cardiologist or a medical practitioner, so that if required, patient can be taken up for a balloon angioplasty or a different kind of intervention as per the need of the patient to save a patient's life, though he may be absolutely asymptomatic. So there are different ways of looking at a history, but basic simple history of looking at different systems, like looking at the respiratory system for dyspnea, chest pain, any blood in your cough, GI symptoms, having loose motions and vomiting, the abdominal pain, tenesmus before the loose motion or after the loose motion, any history of hematemesis or hematochezia, or any history of melena, black stools. Now, black stool points you towards a bleed in the upper GI tract, whereas fresh stools like hematochezia could point you towards a bleed in the lower GI tract. So it could be because of colon cancer or diverticulitis. It could also be because of piles, which may be a benign disease. A simple history of multiple sexual exposures, but not coming with fever, but coming with dry cough and some swelling in the neck could point you towards an HIV. Of course, HIV presents in a myriad of fashions. I'm just giving you an example. And a very basic, simple history taking of a person. A person came to me with a history of intermittent fever coming off and on, going on and on. And there was no other symptom, but then he would say that I get a little dry cough, and he would take some medicines and he would get fever. Now, that he would take some medicines was something I assumed it would be because of paracetamol. I never realized till I went into the detail and found out that he was addicted to taking different kind of antibiotics. Typically, he was taking azithromycin and cefuroxime acetyl. I won't take the brand name. He was taking a particular brand on a regular basis from the medical store, because OTC in India, everything is available in India. So he was taking that because one of his relatives could get better with these medicines whenever they had sore throat. So every time he would have cough, he would take these medicines for some 7 to 10 days, and he would feel that the infection could be taken care of, and he need not visit a medical practitioner. In the bargain, he was getting fever at the end of 4 to 5 days, and that he came to me that my fever is not going. So he was worried that the cough, though being treated by him appropriately, was not responding and the fever was coming. So was there some disease like cancer, So he had that feeling, and it turned out to be drug fever. So I told him ultimately not to take drugs unnecessarily without medical intervention, medical practitioner's intervention. So another atypical case, people presenting with simple abdominal pain with no other clue or finding. A simple CBC. Look at the importance of CBC. Revealed basophilic stippling. And when I looked at him in detail, I realized that there are certain lines around the thumb, blue line, led me to the answer that this person is having lead poisoning, is working in an office as a clerk, and he had a habit of chewing on the pencil multiple times. Whenever there was a stress, he would just eat into his pencil continuously. So, these are different kinds of history. When you go into the details of a history, you come to realize another history clue I can share with you is some irritable bowel syndrome. People come with intermittent, persistent diarrheas and sometimes constipation, but none of these diarrheas are persistent in the night time when they're sleeping fitfully, only in the daytime. So that tells you that this is an irritable bowel syndrome, because of which he's having fever and infection. This is not an infection, and it takes you away from the diagnosis of an inflammatory bowel disease or a cancer. So a detailed history and understanding your history as a pathophysiology and correlating it with symptoms and investigation is a sure way to get a good diagnosis and come to the right way to treat a patient. Thank you.
That was a very well put together answer, Dr. Modi. Let's move on to the next question. How should initial laboratory investigation be prioritized in patient presenting with fever?
It's always a very basic adage in medical science, which we have been taught in undergraduate days, and I will emphasize it once again. After 25 years of my practice in Thane, in Ghodbunder Road, and in being a faculty in teaching hospitals, as well as now being in private practice in my own hospital, in corporate hospitals, as well as my own clinic, I've realized that what we have been taught in undergraduate days and during our residency time comes true till today. And in fact, that has helped me save many patients' lives beyond my understanding and updating of knowledge through various medical books and journals. So the basics are very important, and common things always occur commonly is something we see time and again. And one should not be crazy about going for uncommon things or glamorous investigations and glamorous diagnosis, because they do not occur very commonly. They sound very good when you want to impress people. So the way to prioritize laboratory investigation should be ask for the basic investigations first and try to seek your answers over there, and then ask for the relevant investigations which are relevant based on those investigations. Today the scenarios are different. We have a lot of patients coming on their own from a 20-page or a 30-page or a 50-page report generated because some third party, like their employer or insurance company or some other agencies sponsoring their health checkup, and they do a series of investigations, and then they end up arguing with the medical practitioner, why are you asking for more investigations? Let me give you a very basic example. So a person goes to a lab and gets some 60 or 70 testings done. I'm sorry, gets 130 to 150 testing done, like serum arsenic levels, serum beryllium levels, etc., etc. And you realize that this person has got diabetes with diabetic nephropathy or diabetic kidney disease, and you want to have a urine albumin creatinine ratio to determine whether he has macroalbuminuria or not. And that is not done, right? So what has been done is EGFR and creatinine. And then the patients and the doctor feels if the creatinine is normal, if the EGFR is normal, what is the relevance of asking for UACR? And that is important because early UACR can change the way you treat a patient. You might end up putting a patient on an ARBs or an ACE inhibitor or a dapagliflozin to prevent development of microalbuminuria into a frank diabetic kidney disease tomorrow. So this is something which is very important, and investigation should be prioritized based upon your initial investigations. So always and always, a CBC gets a lot of importance. You pick up a lot of information, whether there is microcytosis, whether there is retic count is high, tells you suggestive of probably a macrocytic anemia, whether the peripheral smear of an RBC morphology gives you ideas about whether there is any sickle cell or spherocytes problem, which could tell you why the person is having it is because of hemolysis and not because of hepatitis. So white count, I've already discussed that a high white count, a neutrophilic shift, toxic granules are suggestive of a septicemic process. They're suggestive of a bacterial process rather than a viral process. A lymphocytic predominance could suggest you towards a viral process, though that is not very reliable. But an ESR is something which is very important. ESR above 50 generally is considered significant and could be seen in multiple conditions. But an ESR that we end up seeing 70, 80, 100 and above give us clues as to the presence of an underlying occult malignancy or tuberculous lesion. Today, we see a lot of extrapulmonary tuberculous manifestations. People come with tuberculosis of the lymph nodes, of the skin, of the genitourinary tract, and not necessarily of the pulmonary system with a high ESR. And people keep exploring, and they end up finding out that this person has got tuberculosis in a site other than pulmonary, that to which most of us are used to. So prioritizing your investigation with the basic things like ESR, CRP, white count, hemoglobin is important. Also very important is a simple stool and a urine examination, costing hardly 40 and 60 rupees. Many clinicians feel these are irrelevant in today's time of 2000 onwards. 2025 is the current year of practicing, and you feel this is not relevant, but it is very much relevant. Casts in the urine can give you ideas about glomerulonephritis. Occult blood positive in the urine can give you a lot of ideas about a potential kidney stone, which may not be picked up on a sonography. Some stones are not picked up on an abdominal sonography, but a positive occult blood in the kidney could tell you that there could be a nephrolithiasis. It can also point you towards an early malignancy. So a presence of pus cells in a diabetic could eventually land up and let you know that the person may be suffering from pyelonephritis. So a lot of clues are generated from a basic report like a simple urine report. Presence of worms in the stool, presence of occult blood in the stool, 1 plus 2 plus could be because of an underlying piles, but a presence of a 4 plus occult blood with a normal sonography, like I already discussed, can end up telling you the person is having probably adenocarcinoma of the colon. And we have picked up people with normal sonography with 4 plus occult blood, eventually leading you to a diagnosis of adenocarcinoma, sometimes leading you also to a diagnosis of diverticulitis, which was picked up after doing a colonoscopy. So, but the person presented only with history of occult blood positive, and at the same time had multiple flatulences from the tummy. And that when went into the diet, you realize that the diet was very poor in fiber, and he got eating outside multiple times. We have I won't name them, but we have lovely apps on the mobile through which we order food from outside, and two apps are very popular. So he ended up eating a lot of junk food from outside, which was infected multiple times, and that is how he got diverticulitis. I'm sharing some real life scenarios. Another real life scenario which I want to share, which is very relevant, is we keep looking at HbA1c, and we see that the HbA1c is under control to tell us that the diabetes is under control. So I had a patient who was an elderly person whose children were settled in the US. So the gentleman was left to himself to take care of himself, and the family relied heavily on me to do that treatment and the therapy. And I was happy that the HbA1c was under good control of 7 and 6.5 for more than 6 months. And I told the gentleman, "You're doing well, so don't worry, and that means your diabetes is under control." But I didn't realize, because when he started having he didn't have symptom, he had little abdominal pain, and when he had occult blood 4 plus positive in the stool, and I started wondering what is it, and then I realized that his hemoglobin was actually low. It was around 6 or 7, and since the patient was asymptomatic, and we generally don't check CBC every 1 month, right? So when the CBC was checked some 6 months back, it was around 10, which was considered okay for his age. And after 6 months, when his ocular blood came positive and his HbA1c was under control, and I naturally thought the diabetes is under control. And then when we investigated, and we found that the CBC was low, and further investigation revealed that he had adenocarcinoma of the colon, which was very silent and hidden. So what's important, moral of the story is, whenever you're doing HbA1c, may not every time, but at least once in 6 months. And that is a practice that I follow. Like, I was able to pick up this lesion early in this patient because I asked for a repeat CBC within 6 months. So one should ask for a CBC with HbA1c, because HbA1c is a combination of hemoglobin and glucose. So just looking at a normal HbA1c could misguide you, because the hemoglobin could be low, and that could be the reason HbA1c comes down, and not necessarily because sugars are low. So a good understanding of basic investigations is what I would emphasize in the answer to this question, rather than go for exotic investigation, which are obviously important. They help you to make a diagnosis. Nobody is underplaying the role of a CT, an MRI, or a PET scan, but the approach for a clinician should be an evidence-based medicine. Give a lot of investigation. Start from first ladder. Start from the basic investigations, and then step up to the exotic and the costly and the higher end investigations, as per the clinical presentation of the case and as per the findings of the initial investigation. Always remember, paramount is to treat the patient and not the reports. So you do find certain investigation which may be abnormal, but that doesn't mean that they have to be treated, because they may not be relevant to the patient's condition. Another classic case is person coming with persistent hypokalemia and not responding in spite of giving enough potassium supplements, turns out to have hypomagnesium as a cause of hypokalemia. And then you realize that this person's magnesium levels need to be corrected, not just potassium. So again, I'm trying to emphasize that investigations are important. They should be looked into it, but they should be tailored as per the initial investigations. A pathophysiology should be built up, and further investigation should be ordered. And that is a good way to practice evidence-based medicine. In the bargain, you don't end up losing the diagnosis of the patient, because the focus here is we need to treat the patient because he's the center of our ecosystem, and we should do the best to get a patient out from his misery and illness in the most appropriate scientific manner as possible. I hope that answers your question. Again, there are a lot of case reports, there are a lot of pearls, and there are so many volumes that you can talk about investigation, because it's a broad topic. But I just wanted to give a small brief and guide the listeners to the fact that we should go in a scientific, systematic manner, and go in a step up manner. Start with the basics, understand them, and then go to the investigation subsequently. Thank you very much.
Thank you so much, Dr. Alok Modi, for such an enlightful discussion covering from pyrogens to diagnosis of febrile illnesses. Your insights are truly incredible for the healthcare professional. And thank you to our viewers for tuning in. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers or participate in meaningful discussions or contribute to the ongoing evolution of healthcare. So until next time, stay healthy, take care, bye-bye.